Hey everyone, I'm Dr. Sarang. Welcome. In this explainer, we are going to get really good at reading the stories our teeth tell us, specifically through radiographs. We're going to focus on mastering how to diagnose both the problems that teeth develop over time and the ones they're born with. So let's jump right in.
So take a look at this. Every single patient, every tooth you see, has a history. But when you just do a clinical exam, when you're just looking in the mouth, you're really only seeing the cover of the book. You can see the shade, the basic shape, maybe a chip or a stain. But the real story, the stuff happening inside, that's completely hidden from view. And that's the thing, right? To truly understand what's going on, we've got to look deeper. And that's where diagnostic imaging comes in. It's basically our superpower. Radiographs are our eyes inside the tooth, inside the bone. They show us things we could never see otherwise, and that makes them absolutely essential for getting the diagnosis right and coming up with a treatment plan that's actually going to work.
All right, so here's our game plan. First, we'll lay the groundwork by talking about the two main categories of abnormalities. Then, we'll jump into the acquired problems you'll see all the time, caries and resorption. After that, we'll do a quick run-through of some key congenital issues. And finally, we'll wrap it all up by talking about how to pick the right imaging tool for the right situation.
Okay, first things first. Pretty much every single dental abnormality you're ever going to find is going to fall into one of two major buckets. And getting this distinction down is, well, it's the very first step in figuring out what you're looking at.
And here they are, acquired and congenital. It's pretty simple when you break it down. Acquired conditions are things that happen to the teeth after the person is born. Think of them like battle scars, cavities, wear and tear, that kind of stuff. Congenital abnormalities, on the other hand, are baked in from the start. They're developmental hiccups that affect how many teeth you have or their size and shape. Okay, let's dive into the big one, the number one offender, the thing you are going to see and treat every single day. Of course, I'm talking about dental caries.
So what really is caries? At its heart, it's the process of demineralization. You've got these specific bacteria hanging out, they eat sugar, they produce acid, and that acid literally just dissolves the tooth. It's that simple, and our job, our whole goal is to catch this process as early as we possibly can.
Now this slide is perfect because it shows how we translate that disease into a language we can read on an X-ray. And our go-to tool for this is the Bitewing. You can see the whole story of a cavity here. It starts small, just in the enamel, that's the red zone. Then it keeps going, still in the enamel, which is the blue. Once it punches through that dentino-enamel junction, we're in the green zone, and things are getting serious. And that purple, well, that's a 5-alarm fire heading straight for the pulp.
And this brings up a crucial point. You have to choose the right tool for the job. For finding cavities between the teeth, the Bitewing radiograph is the undisputed king. It's the gold standard. It's cheap, it's a low dose of radiation, and it's really good at what it does. Now, you might be tempted to use a fancy CBCT, but for this specific task, it's actually a terrible choice. It's not recommended. It creates all these scatter artifacts, especially around fillings. It's not as sharp for catching those tiny early lesions, and it's way higher radiation dose for the patient.
Now, a quick word of caution. Radiographs can absolutely play tricks on your eyes. There are these illusions, these mimics, that can look a whole lot like a cavity, but they're not. And you do not want to be the one who drills into a healthy tooth because you were fooled. The big one you got to know about is called cervical burnout.
So here's the clinical pearl, the pro tip to keep in your back pocket. Don't let it fool you. Cervical burnout is just an optical illusion. It's a shadow at the neck of the tooth that's caused by the shape and anatomy there, not by decay. The key is to trace the outline of the root with your eyes. In burnout, that line will be smooth and unbroken. In real root caries, that line will look like something took a bite out of it. It'll be notched or broken.
All right, let's level up and talk about a much trickier diagnostic challenge, resorption. This is where our standard 2D tools, as great as they are, really start to show their limits. We need to think in 3D.
So in a flat 2D X-ray, we look for the classic signs. External resorption you can see on the left often looks kind of irregular, almost moth-eaten on the outside of the root. Internal resorption on the right usually looks like a smooth, round balloon expanding from inside the canal. The problem is, in the real world, a 2D image is super misleading. It can be incredibly hard to tell them apart or to know the true size and extent of the damage.
And that's exactly why the leading authorities, we're talking the American Association of Endodontists and the American Academy of Oral and Maxillofacial Radiology, put out this joint statement. And it's crystal clear.
For these resorption cases, a limited field of view CBCT isn't just a good idea. It is the imaging modality of choice. This is the standard of care now, because we've learned the hard way that trying to guess with 2D images leads to misdiagnoses and failed treatments.
And boom, this slide shows you exactly why. Just look at that. That external resorption that might have looked vague on a regular X-ray is now laid bare in 3D. There's no more guessing. We can see precisely where it's breaking in, how far it's invaded, and exactly where it is in relation to the nerve. This is information you can't possibly get from a 2D film, and it's absolutely critical for deciding if you can even save the tooth. It's a total game changer.
Okay, let's switch gears. We've talked about things that happen to teeth during life. Now let's talk about teeth that are just born a little different. We're going to do a quick fire round of some key congenital abnormalities you need to be able to spot.
First up, let's talk size. This one's pretty straightforward. On the left, you have microdontia, which just means abnormally small teeth. The classic example that everyone knows is the peg lateral incisor. And on the right, you've got the exact opposite, macrodontia, or abnormally large teeth.
Next, anomalies of form or shape. On the left is fusion. This is where two totally separate tooth buds decide to join together and become one big tooth. The absolute dead giveaway to tell it apart from a similar thing called gemination, count the teeth. With fusion, you'll be short one tooth in the arch. And on the right, we have toroodontism, or bull tooth. Look at that pulp chamber. It's got a normal crown, but the pulp is gigantic and stretched way down toward the root tips. It's a really distinctive look.
All right, pay attention here, because this is a huge topic for your board exams. Amelogenesis imperfecta. It's a genetic defect in enamel formation. And this isn't just academic stuff. It really impacts patients. So this table is your cheat sheet. For the hypoplastic type, the enamel is just too thin, but its density is normal. For the hypocalcified and hypomatured types, the thickness is normal, but the quality of the enamel is terrible. It's not dense enough, so it looks dark or radiolucent on the X-ray.
And check this out. This is a perfect picture of the hypocalcified type. See how there's basically no difference in the shade of gray between the enamel and the dentin? The enamel is so poorly mineralized that it looks just as dark as the dentin underneath it. It's a classic ghost enamel appearance. You could almost be forgiven for thinking these teeth were prepped for crowns, but nope, that's just how they formed.
Okay, we have covered a ton of ground. We've gone from everyday cavities to complex resorptions to genetic anomalies. So now, the most important part. How do we bring it all together into a practical system that you can actually use in the clinic?
So if you only take one thing away from this whole talk, let it be this. You have to have a system. Don't just wing it. Step 1, always start with the patient. Your clinical exam and their history are everything. Step 2, then you pick your imaging based on what you suspect. Simple caries check, Bitewings. Weird, complex resorption, you need to be thinking CBCT. Step 3, when you get the images back, actually look at them systematically. Don't just hunt for the one thing you were looking for. And finally, step 4, put all the puzzle pieces together. The clinical findings, the radiographic findings, to land on that final diagnosis.
So, there you have it. We've covered the fundamentals of how to read these hidden stories. You have the tools now to see beyond the surface, to tell these different conditions apart, and to choose the right technology for the task. So the real question is, as you go out into your careers, what will you discover? Stay curious, be systematic, and never stop learning. Thank you.